Hi guys, this is an introduction to multi-system trauma. So what is multi-system trauma? Pretty obvious, trauma involving more than one part of the body. Now the reason that it's worth having in its own category is that we teach you guys about how to manage a head injury, a chest injury, an extremity injury, an abdominal injury. But if you've got something like a motorbike crash where all the injuries happen at once, what do you do in that situation? Do you treat them all one at a time? Do you prioritize some over the others? This is why multi-trauma is its own area and is useful to have some focus on. So what actually kills people in multi-system trauma? There's only a couple of things. They die of airway compromise, tension pneumothorax, hypovolemic shock, that's the biggest one, or traumatic brain injury. There are a couple of things in there too, like cardiac tamponade, but there's nothing we can do about that. So we'll start with airway. So there are two options to manage the airway in multi-trauma. There's basic management, which is what most paramedics around the country do. And that's the humble bag valve mask. Simple, proven. Downside is that it often requires lateral positioning, which is not only not ideal for spinal injury, which in a multi-trauma patient is something you have to suspect, but also makes the IVs harder to get to and just in general makes the patient a bit harder to manage. We're used to having the patient supine. Basic airway management provides no protection from aspiration or trismus, clenching your teeth. And if the patient's agitated, so if they've got a head injury, they probably will be, basic airway management becomes pretty hard. Now, the other option, which is done in some areas around the country, is rapid sequence intubation. Now this is a complex procedure. It adds to on-scene time and it has mixed results. So a lot of the international data is not very favourable for paramedics performing RSI in trauma, but most of the Australian data has actually showed improved outcomes. So an area of ongoing research. The benefits of RSI is that the patient does remain supine, they get total airway protection and they're paralysed and sedated, so they're controlled, they don't become agitated. Now, Alden's covered tension pneumothorax in his thoracic trauma lectures, but I'll just go over it again. So you have two options for managing a tension pneumothorax. There's the one that is most common, which is the needle thoracostomy, also known as chest decompression. That's when a large gauge, like a 14 gauge needle, is pushed through the anterior chest wall to relieve pressure, normally in the form of air. A couple of problems with it. They tend to worm their way out, those soft cannulas, over time, and while they're good at letting air out, they often become clogged with blood. And a lot of tension pneumothoraxes will also be pneumohemothoraxes, so there'll be blood in there too. If that little tiny cannula gets clogged up with blood, it's not going to let anything out anymore. So the other option, and this is only done by a select group of paramedics in Australia at the moment, but it may be something that rolls down in the future, is the finger thoracostomy. And that's where an incision is made below the armpit in the mid-axilla with a scalpel, and then forceps are used to blunt dissect through to the chest cavity. You don't use a sharp object because you'll just cut the lung. So use something blunt like artery forceps, dissect through to the to the inside of the chest cavity, and then a finger is pushed through and used to sweep around to clear a bit of space and let that blood and air come to the hole that you've created. The great thing about a finger thoracostomy is, rather than having that tiny little 14 gauge cannula, you've created a big hole. So all that blood and air is going to come pouring out. Downside is you've created a sucking chest wound. So in a conscious patient, you're either going to have to put a three-sided dressing on there, or ideally, if you're going to do a finger thoracostomy, you're also going to RSI the patient, and then you'll have positive pressure ventilation so that wound won't suck, it'll just continue to blow out that air and blood that's trapped in there. Now the big killer in multi-trauma, more than all the others, is hypovolemic shock, so the patient bleeding to death. So our focus is on just keeping every drop of the patient's blood in a useful way inside them. So not just pooling inside them, but keeping it in their actual blood vessels. So we want to minimize external bleeding, pad bandage, tourniquet. If you have awkward wounds, particularly junctional bleeds, up in the armpits or the groin, You can't really put a tourniquet on them. The tourniquet only works if the wound's a bit further down the extremity, and they're really hard to put a pad and bandage on too. So for those junctional bleeds, wound packing is the preferred treatment, where you get a gauze bandage, ideally impregnated with a hemostatic agent, and to start packing it into the wound to provide some internal pressure and tamponade whatever vessel is bleeding at the bottom. There is a drug called tranexamic acid, which works by inhibiting the activation of plasminogen plasmin, so the body's normal fibrinolytic function, it inhibits that, so the body will still create clots but won't break them down anymore. It means clots form more readily and they're stronger. There was a big trial called the CRASH-2 trial, which showed an improvement in mortality outcomes for trauma patients who were given tranexamic acid. There is some question about its applicability to the first world. The study was done in a lot of resource austere environments, as well as some questions about what is the ideal time to give it. Is it worth giving it pre-hospitally, or can it just wait to the ED without causing an increase in mortality? So an ongoing area of research, something that may roll down to paramedics in the future. Now bones, we think of bones as just, dry, solid things, but they're actually very vascular when they're in your body, and they bleed when they're fractured. So we all know that the big ones, you can lose a lot of blood, 1.5 litres into your femurs, your pelvis, bleeds into the retroperitoneal space, so you can lose your whole blood volume into there. But even things like your ribs, which only hold about 150 ml of blood each, which isn't that much. But if you break 10 of them, you're up to 1.5 litres. So if you have a patient with multiple fractures from multi-system trauma, you can actually lose quite a lot of blood into your bones. So good splinting in anatomically correct positions is going to be a value added for minimising that internal blood loss for patients. Now when patients are bleeding a lot, they can be eligible for blood transfusions. And if they're given a lot of blood, so the definition here is replacement of all the blood volume over 24 hours or 50% of their blood volume over 4 hours, they've had what's called a massive transfusion protocol. Now blood is better than saline, but it comes with its own problems. So when you give blood at the Red Cross, they take away your whole blood and they break it up into its components. And they'll separate the packed red blood cells, the plasma, which they freeze to become fresh frozen plasma, and the platelets. So when you're bringing a patient in who's going to need a blood transfusion, the hospital needs a bit of time to defrost the plasma, get pathology involved, and basically get those three things made back up into a whole blood substitute. And that takes a little bit of time. So if you can give early notification of a likely massive transfusion protocol, if you've got this massively bleeding multi-injured patient, if you can let the hospital know in advance, they can start that process and get those things defrosting, reconstitute the blood, and ideally have it ready when you arrive, or at least have started the process. Now, a similar sort of vein is the red blanket protocol. And this was designed to get patients up to surgery more rapidly. So they used to have pretty lengthy delays when they looked at the data between getting a patient from the ED up to the theatre who needed to have some surgery from trauma. Could be up to 2 hours sometimes. So the red blanket protocol has managed to get that down to under 30 minutes for a lot of hospitals where it's been done. It's not something you can activate pre-hospitally. It requires consent from the emergency department consultant and the surgery consultant. But you can certainly call ahead to the hospital and say, I think this may be a red blanket case. At least those phone calls can start happening. They can start seeing what theatres they have free then. Now, the current form, this is still based around going from you bring a patient and they stop at the ED, ED does some stuff, and then they go up to theatre. They need an RSI at the ED, they've got to have the airway controlled. They get a fast scan, which is using an ultrasound to find free fluid, like blood, in the abdomen and around the heart and lungs. They may get a CT scan and they get a blood transfusion. Those are things that paramedics more and more are encroaching into. So it's not going to happen in the near term, but in the future, it may be possible that we have a patient intubated, paralysed, we've done a fast scan, found that they've got surgically correctable bleeding, maybe just stop at ED to get a bag of blood hooked up and then straight up to theatre, and bring that time frame down even more to get them up to a surgeon. Now, in hypovolemic shock, it's useful to understand the concepts of controlled and uncontrolled hemorrhage. So it's exactly what it sounds like. Controlled is a hemorrhage that you can control, and uncontrolled you can't fix. But not as intuitive as you might think for some of these things. So if you've got, say, an abdominal artery rupture, like a mesenteric artery, can't do anything about that. It's an uncontrolled hemorrhage. Likewise, if you've got someone who for the last week has had black stools, feeling increasingly weak, they're very pale, they have a slow bleed, a GI bleed in this case, but it's an uncontrolled bleed. You can't do anything about it. Now, likewise, if you've got someone who's had a sudden acute arterial bleed, cut themselves with a knife or something, and they've lost 2-3 litres of blood, but you've controlled the bleed completely with a tourniquet, despite the enormous blood loss, that's actually a controlled bleed now. And they don't need necessarily to be rushed to hospital, and you don't need to do minimum volume resuscitation with them because the bleeding is controlled. Something like a nosebleed, where you've given it a good half hour of pressure on the soft tissues, but it's just still drip, drip, drip. It's a slow bleed, like that GI bleed, but it's uncontrolled. Now, these are important to understand these concepts because it factors into decisions that you're going to make about volume replacement and fluid administration. For an uncontrolled hemorrhage, you're not going to give as much fluid as for a controlled. Now, the last big killer in multi-trauma is the traumatic brain injury. And it's its own category because for every type of multi-trauma, we practice minimum volume resuscitation, which we'll go into detail in another lecture, with the exception of TBI. So if someone has a traumatic brain injury, they can't auto-regulate anymore. They can't manage their own cerebral perfusion pressure. So you have to keep the blood pressure high at an MAP of 90 to still perfuse the brain. That means they are going to bleed more and you're going to have to give them more saline, which is not ideal. But if you don't preserve the brain, nothing else matters.